This is Dr. Hessel dictating a podcast for the CT anesthesia rotation for PGY2s. The title is Pulmonary Artery Catheter Part 1 for September 19th, 2016. Because of potential risk, lack of demonstrated benefits, and appearance of less invasive technologies, pulmonary artery catheters have fallen into disrepute. Thus, many physicians are unfamiliar with pulmonary artery catheters. However, they continue to be used extensively in cardiac surgery, and thus you are provided with the opportunity during your CT anesthesia rotation and CT ICU rotations to learn to use PA catheters to manage complex patients. This requires that you know how to use them safely, obtain accurate information, and apply this information appropriately and be aware of its limitations. That is the objective of these two podcasts. The key points are that, in my opinion, pulmonary artery catheters are currently underutilized. Many physicians have inadequate knowledge. The failure of randomized controlled studies to demonstrate that they reduce mortality do not prove their lack of benefit. Pulmonary artery catheters provide data that is not as easily or continuously or accurately provided by other monitors. The use of PA catheters in echocardiography are complementary. They each provide unique information not provided by the other, and thus are not a substitute for one another. When used properly, the risks associated with the use of PA catheters is quite low and acceptable. The most common complication is obtaining inaccurate information or misinterpreting it, and the keys to safe use and proper interpretation will be reviewed. After its introduction in 1970, PA catheters rapidly became a standard of care for critically ill patients in the ICU and OR. But after about 25 years, their use began to be challenged. This led to a marked reduction in their use, and although many of us believe this is an overreaction and that they should stay in our armamentarium, because of their limited use, clinicians are becoming less familiar with how to use them and to do so safely. Instead of abandoning the use, I believe the proper reaction is learn how to use them safely, learn how to apply and interpret and apply the data, and learn the proper indications and contraindications. Effective use demands thorough familiarity with the complications and techniques of safe use and a further understanding of how to extract, interpret, and apply the hemodynamic data they provide. That is the purpose of these two seminars. I have no disclosures to make other than the fact that I am biased in favor of the use of pulmonary artery catheters. In this first part, we will talk about what PA catheters are, the complications associated, and the proper and safe use, including both insertion and management of these catheters. In part 2, I will discuss the information provided and the indications. The reading assignment is in Hensley's textbook on cardiac anesthesia. There are also other helpful resources, including a PowerPoint presentation that I posted on Wiki last year. Notably, pulmonary artery catheters are still commonly used in cardiac surgery and anesthesia. In this study from the National Anesthesia Clinical Outcome study of the Anesthesia Quality Institute, covering over 116,000 patients undergoing CABG or valve surgery, they found that pulmonary artery catheters were used in about 35% of all of these cases. Furthermore, interestingly, the use of PA catheters had increased between 2010 and 2016 from 26% to 38%. In this survey of Society of Cardiovascular Anesthesiologists members in 2012, they found that for cases, cardiac cases done utilizing cardiopulmonary bypass, about a third of practitioners use PA catheters in all cases, and 2/3 use them in more than 75% of the cases. Only 3% never used PA catheters, and less than 20% used them in less than 25% of their cases. Interestingly, 94% of these practitioners also used TEE in most cases. The pulmonary artery catheter was introduced by Swan and his colleague, Dr. Gans, in 1970. The pulmonary artery catheter is more appropriately called a balloon-tip flow-directed catheter, but is often referred to as a Swan or a Swan-Gans catheter. It consists of a long, about 100 centimeter thin 7 to 8.5 French catheter with an inflatable balloon at its tip. The catheter is placed in a central vein, typically through an introducer in the subclavian or internal jugular. The balloon is then inflated and the catheter is advanced, and the flow of blood directs the balloon-tip catheter through the right atrium, tricuspid valve, right ventricle, pulmonary valve, and into the pulmonary artery. This shows a simple pulmonary artery catheter showing the balloon at the end and the distance markers, which indicate 10 centimeters. So one mark is 10, 2 is 20, 3 is 30. When you get to 50, there's a wide marker, and then a wide plus a thin marker is 50 plus 10, etc. As the catheter continues to be advanced, it eventually wedges into a small pulmonary artery branch, which becomes occluded. Since the balloon occlusion prevents any arterial flow into that artery, the pressure distal to the balloon gradually falls until it equilibrates with the downstream pressure, the so-called pulmonary capillary pressure, which reflects pulmonary venous and left atrial pressure. This shows what happens when you inflate the balloon, and you then create a water manometer connecting the end of the catheter to the left atrium. The balloon is then deflated, exposing the tip to arterial pressure, and thereafter the balloon occlusion pressure can be measured by simply briefly inflating the balloon. After the initial catheter, which consisted only of a balloon and an end port, a third lumen was added at about 26 centimeters to measure right atrial pressure, and a fourth at about 30 centimeters to permit administration of vasoactive drugs, the so-called VIP port. Finally, next, a thermistor was added at the tip to permit measurement of cardiac output. This shows a thermal catheter with the heating coil. This is quite an ingenious catheter, which includes 6 different ports. This shows where the various ports go. And this is the heating coil on the continuous cardiac output thermal dilution catheter. This is then attached to a monitor which gives continuous mixed venous saturation and cardiac output. The advantage of the balloon tip catheter is it can be passed through the heart into the pulmonary artery without requiring a fluoroscopy, simply using the waveform to tell you where you are. Now, the reason why the pulmonary artery catheter became popular was the fact that we need objective hemodynamic data. In this study from about 20 years ago, they found that clinicians were right only about half of the time in estimating pulmonary artery pressures, venous saturation, cardiac output, and oxygen delivery. On the other hand, multiple studies have documented that many practitioners lack basic knowledge needed to use and interpret the pulmonary artery catheter effectively. Therefore, one must become knowledgeable about this. This slide briefly summarizes the data that a pulmonary artery catheter can provide, and these will be discussed in part 2. So what I next want to cover are the complications associated with use of pulmonary artery catheter, and then how to manage these patients to minimize these complications. Why do we need to know about complications? We need them in order to weigh risk versus benefit, to attempt to minimize them, to know what to look for and monitor, and be prepared to treat a complication if it occurs. The complications can be arbitrarily divided between those associated with central venous access, those associated with passing the catheter through the right heart, those associated with indwelling catheter, and those associated with removal of the catheter or exchanging it. On this slide, I have summarized the well-known complications of central venous access, which you are well familiar with, and underline the most important, all of which are operator related and should be prevented by proper technique. Next are the complications associated with passing the pulmonary artery catheter. These include dysrhythmias, knots and coiling, perforation of vascular structures, failure to get into the right ventricle or PA or wedge, dysrhythmia, and then next there are the complications associated with an indwelling pulmonary artery catheter, and these prominently include dysrhythmias, sepsis, and rupture of the pulmonary artery, but there are additional complications mentioned below. However, the most important complications, or the most frequent complications, are getting wrong information or misinterpreting this information or misdirected therapy. One of the most worrisome complications is rupture of the pulmonary artery. The incidence is somewhere between 0.03 and 0.2%. But importantly, the mortality is quite high at 50%. On this slide, I have listed some of the causes and the risk factors, the signs, and how one might suspect it. On this slide, I have summarized the management of ruptured pulmonary artery catheter. However, prevention is more important. And the key is keeping the pulmonary artery catheter in proximal pulmonary arteries as assessed by the chest x-ray and by the amount of air required to obtain wedging. One must always watch the trace while you wedge and only add as much air as necessary to cause a wedge trace, and to stop if you meet any resistance to inflation. Furthermore, you should withdraw the catheter if it takes less than 1¼ cc to wedge a catheter. It is important if you place a pulmonary artery catheter prior to cardiac surgery that you withdraw the catheter prior to going on bypass to typically less than 50 centimeters in most adults. And after you withdraw it, you should make sure that full inflation of the balloon doesn't result in wedge trace. If it does, you need to withdraw further. Another preventive measurement for rupture of the pulmonary artery is to minimize the number of times you obtain a wedge trace. But remember that wedging the catheter is not necessary if the pulmonary artery mean pressure or the pulmonary artery diastolic pressure is low, normal or low. This shows the proper position of the tip of the catheter in a supine chest x-ray. However, if it goes into the left pulmonary artery, which is true in only about 10 to 15% of patients, you can't really tell how far it is in the lung by this x-ray. As I mentioned before, the most common and probably the most important complications of use of the pulmonary artery catheter are obtaining erroneous information or misinterpreting the information and applying inappropriate therapy based on these errors. These are some of the sources of erroneous information and sources of misinterpretation. Finally, there are also complications associated with removal or exchange of the catheter. The greatest risk is air embolization, and therefore, when removing a PA catheter, the patient should be placed in the supine position, and you should cover the end of the introducer with your finger as soon as the PA catheter has been removed, and cap or seal the end of this catheter. This is from the ASA practice guidelines for use of pulmonary artery catheter and summarizes the complications associated with introducing pulmonary artery catheter and while it is in residence in the cardiovascular system. The good news is that the incidence of serious complications is low. The best evidence we have are from 6 randomized controlled trials, of whom about 2,500 patients received pulmonary artery catheters, and you see that there were no deaths in these 2,500 patients, and the incidence of complications were relatively low. Arterial puncture, of course, is not a complication of the PA catheter itself, but of vascular access. Next, let us turn to the management of patients with pulmonary artery catheters, and I'm going to talk about management during insertion, while it's indwelling, and at the time of removal. As far as central venous access, our choices mainly are the IJ, right or left, subclavian, right or left, although occasionally the femoral or antecubital can be used. There are several American Society of Cardiac Anesthesia and ASA guidelines in this regard. This is the ASA guideline for central venous access. My first choice is the right internal jugular, but you can use the left, and if you need to use a subclavian, I prefer the left subclavian, but you can use the right. The reasons for these choices are noted here. For the right internal jugular, it's a direct path into the right atrium, whereas the left IJ strikes the left innominate vein and can cause problems at this point. For the subclavian, the right can strike this intersection here, whereas the left is more likely to go smoothly into the superior vena cava. So, prior to insertion of the introducer, you need to set up the monitor, have the emergency equipment available. A patient should have a peripheral IV, and they should be monitored with at least ECG and saturation, and ideally end-tidal CO2, and if arterial line is placed, arterial pressure. If you are going to place an arterial line, I always recommend that it be placed before you pass the pulmonary artery catheter. Finally, it's critical that you have someone watch the patient continuously while you are inserting the catheter, because you can be distracted while you're inserting the catheter. For internal jugular, one can use either the landmark technique or the ultrasound guidance, although the latter is recommended whenever possible. One should be skilled in both techniques. The traditional landmark techniques are outlined here, and the most common is the apex of the triangle. Unfortunately, the flaw in these techniques is that they are based on unreliable landmarks. They rely on statistical relationships, and although they are valid in the majority of patients, they are not grounded on anatomic relationships. Thus, they can be misleading in a significant number of patients. They rely on statistical relationships, and thus they can be misleading in a significant number of patients. The only anatomically valid landmark for the internal jugular vein is the carotid artery, because both vessels lie in the same anatomic sheath. The internal jugular vein is almost always right next to the carotid artery. The key to successful use of this landmark is proper identification of the location of the carotid artery. One must palpate from the front, not from the side, and you should practice doing this and check it against ultrasound. This shows this technique in which you've palpated where the carotid artery is. The puncture site is then directly next to the carotid artery, aiming laterally. It is critical before inserting either a dilator or greater than 7 French or a 7 French or greater catheter to assure that one is in a vein and not in an artery. Because the consequences of putting a dilator or a 7 French catheter in an artery can be catastrophic. This cannot be consistently ruled out by clinical signs such as spurting pink blood, which has a false negative rate of somewhere between 15 and 20%. Therefore, one must use a Fabian test. Of course, ultrasound guidance is now the standard of care, as summarized in this paper from the Society of Cardiac Anesthesiologists. But I recommend that before prepping and draping the neck, one should first perform an ultrasound survey of the site to make sure the anatomy is favorable and that an internal jugular vein is patent, without clots, and of satisfactory size. I think you still should perform manometry, and I am not confident that documenting that the guide wire is intravenous by ultrasound is adequate to prevent arterial cannulation. After you have achieved central venous catheter access, you're ready to pass the PA catheter. Prior to that, you need to set up the monitor and prepare the catheter. Remember, before removing it from the package, you must do the in vitro calibration. You then check the PA port to the transducer and check that it is connected to the proper transducer and that the zero and gain are proper. One way of doing this is to place the tip of the catheter at the level of the mid-axillary line next to the neck. It should read about 0, and then raise the tip about 30 centimeters, and it should read about 20 millimeters of mercury. One then inserts the pulmonary catheter in the introducer and inflate the balloon when the catheter has been inserted about 18 centimeters, which is about 3/4 of the way of the heating coils. Thereafter, you should advance at a rate of about 2 centimeters a second, being aware of the distance guidelines and noting the pressure and waveforms. This shows the course of the catheter, and this shows the waveforms as you go into the right atrium, right ventricle, pulmonary artery, and wedge. These are the typical distance guidelines when introducing the catheter through the right internal jugular vein. The right atrium is usually reached at about 20 centimeters, the right ventricle 30 to 35, the PA 40 to 45, and the wedge 50 to 55 centimeters. These distances are somewhat larger, I think, with the left subclavian and internal jugular, and even more so if you use the febrile. This is a more detailed picture of the waveforms in the right atrium, right ventricle, PA, and wedge. It is important to recognize the difference between an RV and a PA trace, and the only consistently reliable criteria is the slope of the pressure during diastole. In the right ventricle, the slope is level or rising, whereas in the PA, the slope is declining. This is emphasized in these two pictures. This shows the rising pressure in the right ventricle. Here it's nearly level and rises slightly, whereas in the PA it falls. This again shows a continuous tracing of a patient in which the PA catheter was passed, and here you see the rising slope in the right ventricle and the declining slope in the left ventricle in the PA. While it's in the right ventricle, you should note the right ventricular systolic pressure and compare this with the PA systolic pressure. This is the only chance you have to detect right ventricular outflow tract obstruction. You should also note the pattern of the pressure in the right ventricle during diastole, not only to differentiate between being in the right ventricle and the PA, but also it provides information about the function of the right ventricle. Normally, the rise in pressure is very modest, less than 3 to 5 centimeters. If it's greater, it's a sign of right ventricular dysfunction. And if it displays the dip plateau or so-called square root sign, it indicates severe right ventricular failure. After entering the PA, I usually advance the catheter to the wedge position, although most of the others of our CT attendings don't do this because of concern about PA rupture. Wedge usually occurs at about 50 centimeters, but in some patients with chronic pulmonary hypertension, you may need to go in a lot further. Once it has been reached, I then check to see how much air it takes in the balloon to obtain a wedge trace. If it takes less than 1¼ cc's, it implies the catheter is out too far and you need to pull it back. After inserting the catheter, you need to fix the proximal end of the sheath to the introducer and tape the distal end of the sheath to the catheter so it won't move. You apply a dressing and activate the monitor to measure mixed venous saturation and cardiac output. Obtain a chest x-ray if the patient is not in the OR, otherwise get it postoperatively, and enter a note in SCM. This shows the importance to put the tape over this so this cannot slide back and forth. There are some special problems with using the left IJ and when it's having problem passing through the right heart. The problems associated with the left IJ are summarized on this slide. This shows the issue that the introducer may in fact impale the floor of the left innominate vein, which could cause trauma, prevent the pulmonary artery catheter from going into the proper position, or actually cause it to go through the bottom of the wall, causing hemorrhage. Another unusual anomaly is a left superior vena cava, which is present in about 0.3% of the normal population and will cause an unusual course of the pulmonary artery catheter. This is summarized on this slide. Although most of the time the PA catheter readily goes through the right heart into the PA, at times it is frustrating. This is most common when there's a large right heart, when there's poor contractility or tricuspid regurgitation, and these are some aids that may facilitate getting it to go through the heart. While it's in place, you must continuously display the pulmonary artery waveform and ECG. The lumens must be irrigated continuously. You must always be aware of the volume required to obtain a wedge trace. And before initiating cardiopulmonary bypass, one must withdraw the PA catheter and assure that it doesn't wedge when the balloon is inflated. You must always deal with the catheter if it shows a wedge trace or an RV pattern, and you must use proper technique to obtain a wedge pressure, venous saturation, and cardiac output. Finally, as I mentioned during removal, you must place the patient in Trendelenburg, monitor the ECG, beware of any resistance, and the danger of leaving the wire through the diaphragm. On the next few slides, I have given study questions. Finally, you will find reference lists at the end of part 2 of this series. This completes the dictation of pulmonary artery catheter part 1 for PGY 2 residents on CT surgery CT anesthesia rotation.